Hello, everyone. We'd like to welcome you to today's webinar on Introduction to Service and Resource Sharing. We are very happy that you were able to join us. I'm Melissa Seaver. I'm a Senior Advisor for Public Health Systems and Services at PHAB. And I would like to also introduce our two speakers or presenters for today, Travis Parker-Lee. He is a Senior Specialist, Public Health Systems and Services, also at PHAB, and then Grace Gorenflow, who is a Public Health Consultant. We're lucky enough to have with us here at PHAB, and she provides subject matter expertise in the service and resource sharing space. So if we could just very quickly, those of you that are here as participants, if you could introduce yourself in the chat by giving your name and where you're from, that gives us a sense of who's with us today. That would be very helpful. And then as all of you are introducing yourselves in the chat, I want to just quickly mention a couple of housekeeping items. Travis, is our chat working? I'm not seeing anything come through, but it might be me. Oh, there we go. Thanks, Laura. Fantastic. So please continue to introduce yourself in the chat pod, both name and where you're from. So a couple of quick housekeeping items. So please continue to use the chat throughout our time together. It's a great place to ask questions, interact with the presenters, interact with each other. I also want to note that you have control over your microphone. And so if you want to come off mute to ask a question or to make a comment, feel free to do that. But when not speaking, we just ask that you please mute your microphone to cut down on the background noise. We also encourage the use of the interaction tools that we have available to us through Zoom. So the raise the hand, the other emojis, again, feel free to use those as you choose. We will be recording, but please note that we're using this recording for our own internal purposes. We do not plan to post. And then lastly, if for some reason you encounter any technical difficulties, we would just encourage you to log off and then log back in. And if for some reason something happens on our end as the host, we will follow up with everyone via email regarding next steps. So Travis, next slide, please. So here is the agenda or the topics that we will be covering today. So I'll start in just a moment with a high-level overview of public health systems transformation. And then we'll turn it over to Travis and Grace, who will provide an overview of service and resource sharing. And I might refer to it as SRS. Just know that when I say SRS, I mean service and resource sharing. We'll then also share some tools and resources that are available to support health departments and health department systems with service and resource sharing arrangements. And then we'll also touch on some of the technical assistance that's available through PHAB. And then lastly, we want to make sure we leave plenty of time at the end for more discussion and any final Q&A. But again, this is a small group, so we encourage you to ask questions throughout our time together, again, either through the chat or you're welcome to take yourself off mute as well. So with that, before we jump into content, I'm going to turn it over to Travis. We have a couple of polling questions for you just to get a sense of where you're all coming from. So the first question is, how familiar are you with service and resource sharing? And you select one of those responses. I'm not familiar at all. I have a basic understanding, or I have direct experience with service and resource sharing. Give you a few seconds to respond. Great. So I think we've got three respondents. The majority have a basic understanding or eager to learn more, and we have someone who's not familiar at all. So that's helpful to know. As Grace and Travis, we can all accommodate that throughout our time together. And then the next question, what are you hoping to get out of today, and selecting all that apply? Oh, have they already answered that, Travis? I'm sorry. Oh, I didn't scroll down. My apologies. And so great. So everyone's eager and willing to listen and learn more about service and resource sharing arrangements. I think we can handle that. Fantastic. So thank you. That's just helpful in giving us really just a sense of where everyone's coming from. Right. So before we jump into talking about service and resource sharing, we want to provide a little bit of context related to how service and resource sharing, or SRS, fits into broader transformation efforts, and then also the PHIG grant. And so this slide shows PHAB's definition for transformation. It's a lot of words. I'm not going to read it. But in short, transformation really requires keeping what's working or sustaining what's working, improving upon those things that can be improved, and then reimagining really what could be, so that all people in all communities can thrive. And another point that I'd like to call out as well related to this definition is that transformation occurs through a fundamental shift in the way that a system is structured, functions, and interacts. And so that fundamental shift is really integral to transformation. So Travis, next slide, please. Slide is intended to provide a visual depiction of that shift or continuum across which transformation occurs. And I think what's important to note here is that transformation can be iterative and incremental, which you see more on the left side of your slide, or it can be more radical and disruptive, which you see towards the right side of the slide. And I think typically in public health, we see transformation occur over time through a series of smaller improvements to systems, structures, processes. This is where quality improvement typically occurs. But ultimately, over time, those smaller incremental changes result in a fundamental shift in the way that the system is structured, functions, and ultimately interacts. And then on the right side, you have the more abrupt and disruptive change. And typically, but not always, this occurs over a shorter period of time. And it's often, although not always, influenced by an event in our environment. And a good example would be, 9/11 and the changes to the structures and the systems and the way that we functioned related to emergency preparedness in this country post 9/11. So innovation is in the middle because it really has a role both in these incremental iterative changes as well as the radical changes. Innovation really being the design and implementation of new and novel creative structures, programs, services that are intended to improve health and equity. So it spans really both sides of the continuum. Next slide, please, Travis. So hopefully you can start to see how service and resource sharing, even if you really don't know anything beyond the title itself, service and resource sharing can really have a role in system transformation efforts, as the way that we deliver services through shared agreements can really shift the way that a system looks and a system functions. So in addition to service and resource sharing, which you see right in the middle of the slide here, PHAB has a variety of other resources, guides, tools that we collectively refer to as our tools for transformation. And we're not going to cover these today other than service and resource sharing, because that's why we're here. But these tools and resources can be used independently, but also in conjunction with one another to support infrastructure improvements and transformation efforts. And I know we'll talk a little bit more about how some of these tools can be used in conjunction with one another over the course of the next hour. So lastly, I want to make the connection to the PHIG grant. And Travis, next slide, please. The PHIG grant has provided our health department systems with, a historical investment in transformation and system improvement efforts, in a way that we really have never seen before. And so today we hope not only to increase your knowledge around service and resource sharing, but also to begin thinking about how service and resource sharing can be a solution to identifying some of the gaps that you may be identifying across the PHIG strategies. So as we think about workforce and capacity, how can service and resource sharing tools contribute to increases in staffing and expertise? How can it contribute to the delivery of foundational public health services within a jurisdiction, a region, across a system? And then also, how can service and resource sharing support capacity related to data modernization, like through the sharing of IT infrastructure, joint purchasing power of data systems, et cetera. And again, I know Travis and Grace will be touching a little bit more on that a bit later. So we're looking forward to hearing about some of your challenges as well, and where you feel that service and resource sharing could be a potential solution. So we invite you again to ask questions throughout our time together, and also share comments and experiences as well. So with that, I'm going to go and turn it over to Travis.
Thank you so much, Melissa. So likewise with the public health transformation definition, we do have a definition for service and resource sharing. Again, I'm not going to read this, but this is what we mean when we talk about it in the context of public health and transformation. I did want to highlight the piece that is in green that you can see here, around sharing resources across boundaries to more effectively and efficiently deliver services. And in this context, when we think about what effective means, it can refer to doing better in your programs, like increasing capacity to reach populations that you normally wouldn't or haven't been able to before, and even enhancing quality. And then thinking about being efficient, typically cost savings comes to mind, but we want you to think beyond that and really making the most of funds and resources that you currently have available. And under the infrastructure grant, those are aplenty at this point. I did want to note that to date, our learnings have mainly been around 2 to a few health departments coming together to share things. But we do recognize here at PHAB, especially through our innovation and transformation work, that sharing services and resources can go in many different directions and can entail a vast number of models. So just keep that in mind as we go over some of the approaches and tools and resources we have available as we are still learning, and hopefully we'll learn from the PHIG grants over the next several years in order to support you. So in this slide, just outlines a summary of a one-pager that we have available, which is intended to help health departments and governmental public health systems conceptualize the range of possibilities when it comes to service and resource sharing arrangements. And we want to also help stimulate ideas about how to approach these efforts that, again, increase that effectiveness and efficiency of service delivery in either a community, a region, or throughout a whole state. So these 3 approaches are on that one pager. The first are local approaches, which involve 2 or more local health departments working directly with each other to share service and resources. Some examples that we've included on that one pager include 2 or more health departments coming together on an as-needed basis, which is, again, pretty informal, not as loosely integrated, as we like to say, in those arrangements and whatnot. Another example includes a local health department purchasing a service or resource from another local health department, so that one-to-one relationship. Another example is that 2 or more local health departments share a service or program with joint oversight, identical policies, procedures, and shared staff. So integrating a little bit more. And then lastly, the example we have is 2 or more health departments that fully integrate together, which usually results in a single operational entity. The next approach in that one pager, we talk about regional and district examples, and those refer to services and resources offered by an entity that serves a subsection of a state. So some examples include state health department establishing district or regional offices that provide all public health services in that jurisdiction. Another one is a state health department funding local health departments to provide specific program services for others in the state, or in the sub-state area, I should say. Another example is a local health department purchasing services from an entity that serves the sub-state area where the department is located. So that notion of one-to-many relationship. And then lastly, a local health department establishing a regional identity to facilitate resource sharing. So this can be seen as like a partnership, a consortium, or even a council of governments. And then lastly, we have our state level system-wide approaches, and those refer to services and resources offered by a single centralized entity and or a state health department, has a strategy to promote service and resource sharing arrangements among local health departments in the state. Some examples that we've listed here are a state health agency provides a service or resource to all of the health departments in the state. A state health agency may provide some incentives to encourage local health departments to develop service and resource sharing arrangements. A state health department may fund a single local health department to provide a service for all other health departments in the state. So that notion of, like below, the notion of a one-to-all type arrangement. And in the last example, you could have a local health department that purchases services from an entity that serves the whole state, like a state association of county and city health officials or a state public health association. I did want to note that while these are brief examples and definitions, we intentionally did not put a specific number of participating health departments or organizations to these approaches. Many arrangements can be characterized by more than one approach, as we've seen in some of our examples. Like I said earlier, we do recognize that there's a wide diversity of approaches that exist in the field, and we do hope to capture and learn more from all of our grantees. So with that kind of conceptual description of our approaches, I'm going to turn it over to Grace, who's going to share real life examples that hopefully kind of embody and show how these show up in real life. So Grace, I'll turn it over to you.
Great, thank you, Travis. So we can move to the next slide. So we put together a few different examples, intentionally highlighting different states. And I see that, whoops, sorry if you can go back. I see that none of these examples are from the states where anybody on the call is from, for better or for worse. So, okay, please go ahead to the next one. I should also say, Laura and Kate and Adele, I hope you're not feeling outnumbered, even though technically you are. And I know that everybody said they really just want to listen and learn. Because it's just us, it is really, really easy for you all to, for us anyway, to answer any questions or clarifications. And please don't hesitate to stop and even see if I might have more examples that I can share than what's up here. So when it comes to the first example, the first category of examples, these are local level examples. And we haven't looked very much at all at informal as needed agreements or simple purchasing agreements, because health departments tend to do this, local health departments anyway, tend to have these kinds of agreements in place. Okay, Portland. Ooh. Talk about Oregon, and I'll ask about, I mean, I can mention Oregon. Anyway, they tend to have those kinds of agreements in place anyway, you know, just by a matter of course, and they're relatively simple and straightforward. So I have two examples from what we would call the far end of the spectrum, where two different health departments are several health departments became much more tightly integrated. And this is a pretty interesting model. This one here, I think, because it didn't actually involve a consolidation. After I talk about this model, before we move to the next slide, I can talk a little bit about Oregon and an example in Oregon. So Go Health, Genesee, Orleans counties. This is These counties are in the western kind of panhandle-ish of New York State, very rural area. And they, both of those counties, and they are bordering counties, realized that they were essentially competing for health officers. And you all know that it is terrifically hard, unfortunately, to hire people in and to find really good candidates. That's definitely exacerbated in rural areas, not as much in a place like Portland, but certainly in various places in Wisconsin. And so instead of competing with each other, they decided it would be interesting to see if they could share a health officer. And what started off as a pilot project, they had an MOU that was in place just for a year to look at what it would be like to share a health officer. And then there was also a clause in there where you could also share a deputy if you have a deputy, and potentially expand. Well, after the year was up, they were sharing a full management team, and since then, this was in the mid 20-teens. Since then, they've expanded. They've added some additional staff who are sharing services. Who are working on behalf of both health departments. But otherwise, each county has a health department. Each of the health departments has the existing staff that they had. They take turns hiring people who will be cross-trained to work in both jurisdictions, but they have their set physical location. And in addition, there are some staff who are specifically hired to do the same job in both. They also have cataloged their cost efficiency, their savings, but it's not just savings. Travis mentioned that one of the points of engaging in an SRS agreement is to basically get the biggest bang for your buck, and to not only, so you're not only thinking about, are we saving money? You might not be saving money, but you might be able to afford to do something that you couldn't do before, and you might have other benefits that come as a result. And they've got great information on things like they were able to get a CDC intern once they became this particular entity because they had a larger population. They got more favorable contracts. And so the smaller of the two health departments ended up paying less per unit for a few different contracts that they have. And they do have some out and out cash savings, of course, when you have one position serving both counties, but there are many, many more examples. In fact, they would have outright merged were it not for New York State statute that got in the way of that, but they have a workaround. And the other, they did this as a workaround. They also, the real key to their success was the fact that their county administrators had worked well together for years. They'd shared things for years. And they had a very solid reputation and a relationship and a lot of trust between the two of them. So that's Go Health. So I cannot do two things at once, but I am going to switch now to respond to what came up in the chat. So, okay, so a Tri-County Health Officer Partnership. And Laura, you are currently looking, okay, into the development of some multi-county partnerships. So I have to say, I'm going to pause for a minute. And Kate, I'm just going to ask you, first of all, if you could share with Laura what your, and I've actually heard about, I think I've heard about this one. I heard about another one of these in Oregon. But could you please describe the partnership that you all have?
Sure. Hopefully you guys can hear me. So we're in an urban area, and the other two counties that are nearby us, all that Are similar geographically and are pretty diverse in terms of not close in comparison to Portland's diversity levels. So that would be Washington County and Clackamas County. We have what we call a tri-county health officer partnership. So the health officer is housed and is a Multnomah County employee, but works in collaboration with their two deputies, which and oversees the Washington County and Clackamas County. And like similar to the Glennees and Orleans County, we have our own team, we have our own staff and our own teams within each department, within each county. So it's similar to that, and it's also helped alleviate many of the recruitment issues, and also when things do happen here in Multnomah County, it eventually trickles into either Washington or Clackamas in a way. So it's really best to have sort of a collaborative work through and be able to kind of work cohesively, and everyone knows what everyone's doing already, because it's like a tri-county initiative. Does that make sense? Kind of. We did something similar to that with COVID, with having a regional JIC, which and a regional emergency operations center also.
Great. Thank you for sharing that, Kate. And it's, your example also, I think, is really helpful. You're reflecting the fact that public health problems don't have geographical boundaries, right? And so it's really in everybody's best interest to work together. Which also makes me think about some work that was done down, was it Marion and Polk counties, down where Salem is. I know that you know that, Kate. But they worked together, and this was part of one of the earlier parts of your state's transformation efforts. They got one of the grants to work together on communicable diseases, and it was mutually beneficial because there was so much traffic. There is so much traffic, since Polk County has a bedroom community for Marion County, for Salem. It just made sense. If you can control it in one, you can better control it in the other. And so they were able to share a lot of resources, especially when it came to, so they could help each other out if there was a major outbreak. I'm sure that paved the way for what happened during COVID, but regardless, that also meant that they could engage in the same communications campaigns to encourage prevention and that kind of thing. Oh, you're on mute.
So I was just saying the sharing of resources was really important, and it was only highlighted in the fact with COVID. Our first official COVID case was a gentleman who worked at a school in Clackamas County but lived in Washington County. So being able to being the tri-county officers being able to coordinate that, and then and just even the communications that went out about that, because he worked actively in a school, elementary school, no less. It was quite it really highlighted the need to be able to share resources and collaborate before, a big panic came out. I still actually remember that because it was a school actually where I live.
Oh, wow.
Yeah. And yeah, so it was, but he's fine though. He was great. He stayed 42 days in the hospital, but he fully recovered. He was our first official COVID-19 case.
But back when people could actually count on their hands and trace the cases and not just look at the labs, or the water. Thanks for sharing that. And I think, so the other thing to think about, and we're going to depart a bit from the slides, which is what we were really actually hoping to be able to do to better meet your learning needs. So Kate, what you described about your partnership, and I'd love to follow up with you in the future to learn a little bit more about that. But what you described is a lot easier to do than to merge or consolidate health departments. And Laura, oh, great. Thanks for your note, Laura. And I've been reading all the notes in the chat. I think, Laura, when you talk about like having some kind of a multi-county partnership, that is certainly going to be better, easier in most regards than combining. And I think that's something that we've really learned over the years about sharing services, is that if you talk about it, if you say we want to regionalize or whatever, people automatically think consolidation. And I'm sure you're aware of Washington and Ozaukee counties and how they actually did consolidate several years ago. But you don't have to do that to get the efficiencies. There is, for example, a coalition of 7 counties down in the southeastern part of Kansas, all have their own health departments, but through a collaboration, they share things like WIC services and family planning, and I think emergency preparedness, and maybe a few other things. So they all still have their own governance structures, and so you get a way, you kind of alleviate concerns around those kinds of things. And that's another example of what we call a local approach, but quite honestly, it could also be a regional or district approach, depending on how you look at it, which is why with our categories, we're not really stuck in trying to fit any model in. Rather, we're just trying to show that there are a lot of different ways to do this. We also have, but I would say, depending on the staffing issues, Laura, it might be worth it to take a deeper dive into GoHealth, because it's just so, at least in our minds, incredibly innovative. And they have, the other thing I'll tell you about GoHealth is that in addition to sharing their management team, and they have the same policies and procedures when it comes to needing to send somebody out, for example, to a statewide meeting. They only have to send 1 staff instead of 2, which is really helpful. And I know there was one other thing I was going to say about that. Anyway, but they do have there's a lot of information there. Oh, I know what it was. It was the Board of Health. So according to statute, each county has to have a Board of Health in addition to its own health department. And so the way they got around that was to combine the boards of health. So the bad news for the health official is that they went from having 5 board members to having 10. On the other hand, everybody still has their hand in the pot. And so that has gone a long way, I think, in terms of alleviating concerns about who's making the decisions anyway, which can be a very big issue. There are other examples, and in fact, Travis, if you could go forward a couple of slides to either San Joaquin or San Luis, whichever is the first one that comes up. There are also examples that we have of partnerships where we've got 2 different examples, one that is fairly loose and the other one that is much more integrated. But in Colorado, there are 6 counties that basically comprise the San Luis Valley, which is a high desert area that's geographically isolated because of the Rockies. And if you've ever been to or heard of the National Sand Dunes Monument, it's down in that area. And they have worked together for years. They have this sense of we're all in it together. All of the county commissioners have felt like that. Public health departments have felt like that. And they came up with a formal partnership, but formal really only because they decided to put in some guidelines to their to how they work together and that kind of thing. They don't have, they rotate leadership. They only have a part-time coordinator who basically helps with meeting logistics and sometimes with grant writing. And so what they do, they're all set up so that they don't have to go through any kind of song and dance with their various commissioners to make sure it's okay to get a grant or to share a grant or whatever. They have this partnership that has been okayed to work as, a unit, if you will, on behalf of all 6 health departments. and that, again, I mean, it's pretty informal, even though they've got like guiding principles and that kind of thing. But then we have another example in California, San Joaquin Valley Public Health Consortium. And it's a completely, there's a different party, like a third party at play here. And that's the UC Fresno Foundation that has provided office space for consortium staff. And this started right before the pandemic and it has since blossomed. So they have a dues structure and San Luis doesn't. These guys have a dues structure. It goes like the smallest health department pays, it's per capita, pays like $700 a year, but the largest, Fresno, pays about $32,000 a year. And now they have several staff that work on behalf of, what is it? I can't, maybe, I want to say it might be 11 counties. It is 11, sorry, yeah, it's right up there. And so it is much more, that's much more of a thing, right? I mean, it takes more resources to pull that together. But it's another model to think about, just depending on how many health departments it is that there are that you get together. And then Laura, the other thing I just wanted to quickly mention about Wisconsin, and you're probably aware of this, but both with Washington and Ozaukee counties, when they merged, and in Oshkosh, when they changed, the county health department changed configuration because I think they added another city into their county health department. But with both of those, they used the opportunity of changing their structure to become a Public Health 3.0 health department. So I wanted to be sure if you hadn't already heard about that. For all I know, you were one of the architects of this, but it's just, they're great resources. And Kirsten Johnson was in Washoe counties when all of this went down. So anyway, and you're probably well aware, but any questions, any other specific questions or comments?
I just want to say thank you. I didn't mean to hijack the meeting. Yes, I'm aware of the Oshkosh area. I think mainly just to add a little bit more context, mainly what we're looking at in Wisconsin, we're decentralized. So many of these coalitions that have developed have been, developed by the counties. They have the relationships with each other. So we're looking to encourage that more widely, as we are seeing, as I'm sure everybody is across the nation, more and more staffing issues. And those are just persisting, and there is a point at which we say, okay, the county right next to you, who is also very small, does have a public health nurse. And we really think you two should discuss options to share that nurse in the interim, permanently, however it may be. But I know this is not just a problem in Wisconsin. I know this is happening across the nation, as hiring is very difficult right now.
We hear a lot.
Thank you. Just wanted to provide extra context.
Yeah. Okay. Real quickly, I appreciate that. And sorry, I'm always curious about this. Can you pronounce your last name for me, please?
Coklaful, like Coca-Cola.
I love it. What kind of a name is that?
It's Bohemian.
Bohemian. Okay. It is so not one of the two options I'd come up with, but I love it. That's really cool.
There's a very similar word in German, so most people guess German.
Oh, okay. Okay. Well, thank you. Thank you for indulging me. We also hear a lot about epidemiologists, right? I'm sure you're facing that in Wisconsin as well. And we do have, now we haven't written up this example, but if it's helpful to talk offline about some other examples, there's one in particular with epidemiologists in Massachusetts that comes to mind. I'd be happy to share that with you and potentially put you in touch with those folks. And I guess, I'm thinking also, well, yeah, I'm gonna hold on that. And Adele, so we've talked a little bit about Oregon, a little bit about Wisconsin. Adele, wondering, okay, thanks. I'm wondering, Adele, if there's any specific question you have.
Yeah, no, thanks so much for the opportunity. I'll come on video too, just for a second. I'm working to support a handful of partners in mostly healthcare, but some in public health, who've talked about shared services in terms of like a tool or a technology that they might leverage across sites. And so I was actually just taking notes about the sharing of human resources in a similar fashion, and how I'd heard that honestly sometimes as a limiting factor when tools or technologies are being rolled out in public health settings, because of only having 4 hours on a Thursday with the IT person who's, at a given site, and how that might impact the ability to upgrade or update systems. But then at the same time, looking at it from this opposite lens is really helpful for me to understand how folks are addressing a limited hiring pool or limited resources that might be able to meet the needs. So I'm really just learning and taking a lot of notes. I think it's particularly helpful for me in Georgia, where our public health department is just chronically underfunded and likely will continue to be so. And so, how might those strategies will be applied here is interesting. Thank you.
Well, yeah, sure. And then I would also say that we do have a story about a consortium in Florida, kind of a loose consortium of health departments, where they shared IT services. If that's, if an example of how that's been done would be helpful. And I'm going to stop in a second and so we can get on to Travis and he's going to talk about some more tools, but I'm not sure if this was on the list of things we were specifically saying would be helpful. We do have kind of a checklist if you are going to be sharing staff.
Yeah, that's great. That's really interesting to me. And then how folks approach maybe some of the like administrative tasks or requirements to support this infrastructure or this approach, because we often find that whenever legal or compliance come into the equation, that's really hard. It's really hard to manage differences from jurisdiction to jurisdiction. And so, yeah, thanks for the opportunity to learn.
Yeah, sure. So I'll stop. And Travis, let me hand it over to you.
Thanks so much, Grace. And thanks for teeing up the tools and resources that we will talk about today and have available. As Grace mentioned, we have that checklist. We can make sure we send that to you, Adele, after the meeting. So as I mentioned earlier today, we do have that Approaches one pager that is up on our website, currently available. And then we are almost ready to post a state guidance document. This is intended to help equip states, the state health agency, I should say, and their staff supporting all service and resource sharing arrangements that might happen within the state, whether that's at the system level, the regional level, or local level. The next product that we have is our roadmap, and this is intended to be a guide for those that are working on or considering sharing agreements for their public health services. And then lastly, we have two tools that kind of go together, a collaborative trust scale and success factors. The trust scale is a tool to help evaluate levels of trust between collaboration partners. And then the success factors lay out features like prerequisites, facilitating factors, and project characteristics that can increase the likelihood that any sharing arrangement will be successful. So you may have seen these tools and resources in a different iteration, but we went under a process to review and update these products that better reflect what we've learned through the last few years. and then also incorporate PHAB's IDEA concepts. Those are our inclusion, diversity, equity, and anti-racism principles that we have as an organization. And like I said, some are already up on our website and some will be released in the next couple months or so. And then with that, I'll turn it over to Melissa to close us off with some technical assistance details.
Great. And Travis, I don't know if you mentioned, but I did post the link to our service and resource sharing website. I might have missed that if you said it, but it's in the chat. So
thank you for doing that. Appreciate that.
Yeah, easy for people to access. So related to technical assistance, just a couple of things that we want to mention. First, PHAB is one of the 3 national technical assistance providers that's funded through PHIG, or the Public Health Infrastructure Grant. And so that gives us the ability to provide direct technical assistance at no cost related to this topic. Also across our other tools for transformation mentioned earlier. And so as PHIG grantees, if you're familiar with PHIG, that's the system where technical assistance requests can be made. If you're not the PI and don't know about it, you might want to ask. But you can make specific requests to related to or for TA support through that PHIG system as it relates to your PHIG work plan. So just wanted to remind everyone of that. Some of the technical assistance that we can provide, just general consultation and around understanding more about service and resource sharing arrangements, just talking through strategically, how you might approach this in your department or in your health department system, your context, your specific situation, how service and resource sharing might or might not, be a fit. Thinking about how to assess needs, whether it be things like the readiness assessment or the capacity and cost tool, which can help uncover gaps that could be addressed through service and resource sharing arrangements. And then generally just thinking about other places where SRS might be used. I think about accreditation coordinators because that comes up all the time as well. Nobody can't find accreditation coordinators anywhere. Environmental health staff, etc. The other thing that we can provide as well, in addition to general consultation, is training, additional training for staff and system partners. So we can provide overviews or we can dive deeper into some of the topics that we covered today. And then lastly, we could also consider workshops where you really start to apply some of the service and resource sharing tools, start thinking about arrangements, policy considerations, and what that arrangement or agreement could look like, and doing that in more of a workshop fashion. So I will pause there and open up the floor for any final discussion, comments, thoughts that are front of mind, any last Q&A.
I'm just going to quickly add something. So as you all move forward, if you're in a position to support sharing arrangements, we always really encourage folks to look at the success factors that Travis mentioned, and really give those due consideration. And then also follow the roadmap, which is basically 3 parts. It's a conceptual, encourages you to do sort of a conceptual feasibility analysis, but big words, you don't have to, depending on what it is you're setting out to do, it doesn't have to be a massive undertaking. It really is intended just to be thoughtful, to make sure that you're getting off on the right foot and that sharing really is something that is feasible for all of the partners. Then there's the operational feasibility piece, where you're just led through a number of different issues that come up, with some resources to help address the issues. And then the final phase is implementation, and a few notes to help ensure that there's smooth implementation. Now, this is, even if you're looking at sharing one staff member, simply sitting down with a group and going through these things and having a conversation can be super helpful to make sure that you haven't left any stones unturned. And this is particularly true when it comes to the first phase, the conceptual feasibility piece. We've seen folks who kind of dive into planning, but they haven't really specified what's on the table or what's off the table, or any, trust issues, which is where the collaboration scale can be really helpful to surface issues in a neutral fashion. So really just encourage you to take advantage of these, and you can adapt them as you see fit. Like I said, I mentioned a conceptual feasibility analysis, and that sounds huge. It doesn't have to be huge. Skip over things that aren't relevant, but at least be very, very deliberate as you move through these things. Thanks.
Thanks, Grace. Appreciate those additions. To help maybe think of things that might spark some conversation in our last few minutes together, here are some questions for the group. I know we've kind of touched on these a little bit earlier, but again, just want to give the opportunity for folks to let us know, what else is there that you want to know about. If there's something different than what Melissa described in the technical assistance available that you may need, please let us know. Maybe this examples ones won't apply as much since you are still learning about service and resource sharing in general, but if you are aware of any good examples, feel free to let us know too. And then if there's anything else you want to know about, or any other questions you have either about service or resource sharing, or maybe connections to the PHIG activities, we'd welcome those now or at any point really. We're here to hopefully help answer any questions you may have. So if there's anything top of mind now, feel free to come off mute and let us know. If you need to think about it a little bit, that's fine too. We'll be sending up some follow-up information. You can let us know then. But just want to give time and space just in case there's any last thoughts. All right. Well, with that, I will just thank you all for attending. Appreciate you taking the time and for participating and engaging with us today. Like I said, we'll be sending up some follow-up information soon. And that will include an evaluation link. I actually just put that in the chat as well. If you want to go ahead and let us know your feedback. We do take additions to our evaluation forms pretty seriously, and actually amend offerings based on what we receive. So thanks again, really appreciate your time, and I hope you enjoy the rest of your day, and we'll be in touch soon.